focus in on. There's a lot in this content for mom, for postpartum at risk. Notice I say at risk. We're always watching moms for all of these things, okay? So all moms get watched for all of these things. Some of them we're more likely to see initially, so at the time of delivery and immediately after hemorrhage. Some things take some time to develop. So we talked about atony, uterine atony. Another phrase for that is boggy or mushy. It is bad. Boggy is bad. Now you're at risk of having uterine atony if you have an over-distended uterus. So you have two babies in the uterus. If you have high parity, parity is how many times you've been pregnant. So for example, if you're a gravid of 10, para 6, that person's more at risk than somebody who's a gravid of 1, para 1. You had a rapid labor or a prolonged labor. So it's both ends of the spectrum. So how can that be? Well, what happens is when you have a rapid labor, let's say even an abruption, everything happens so fast and rapidly, and then the baby came out, the placenta came out, there's nothing in there, so the uterus kind of goes, oh, and it doesn't do anything. Prolonged labor, uterus is a muscle, I've been contracting, I've been doing this for 27 hours. So then you finally get the baby, and the uterus is like, I'm tired, I can't do anymore, okay? So a precipitous labor puts you at risk, and a prolonged labor puts you at risk. If you're on Pitocin during labor for a long time, you're going to be more at risk, and that is a difficult concept, so I want to make sure and say that clearly. When you're on Pitocin for a prolonged time in labor, you're at higher risk for postpartum hemorrhage, and it has to do with we saturate those receptors on the uterus with Pitocin when you're in labor, so they don't respond as well after delivery. So we really want to use as little Pitocin as we need to during induction and augmentation. Operative birth could be either C-section, but also could be any kind of intervention. And again, it's a complication, so the uterus doesn't go back to its normal state. So chorioamnionitis, I think I mentioned this before. So chorio, this and amnion, those are the layers of the membranes that form the bag of water. We talk about the maternal side and the fetal side of the placenta. So you have Dirty Duncan and Shiny Schultz. So there's infection or inflammation that sets up in that. So chorioamnionitis, usually you know that that's there because mom is running a fever. The baby's baseline in labor is elevated, so very tachy, 170, 180. Very, very sick mom. And so again, if that happens during labor, we're not out of the woods. She could hemorrhage after delivery. Okay. Placenta abnormalities, which again makes sense because you're at risk of having retained placenta, and then general anesthesia. Some other folks who would have uterine atony, the body has a hard time when you have trauma or lacerations of other parts of the body. It's like I can't take care of everything. So I'm trying to kind of stop the bleeding here from the cervix and the vagina, and the uterus can't clamp down all at the same. It's like asking me to do too much all at the same time. And then bleeding disorders, so if you have a coag problem like factor V deficiency and some other things. And then uterine inversion, I have never seen this, but it is where sometimes where the placenta is so ingrained and they kind of pull on the cord, you can actually pull and the uterus comes inside out. So it's very bad. They can try to put it back in. We also have had it happen when nurses did not do bimanual massage, and so you didn't have your hand over the lower uterine segment, so you were just pushing on the top of the fundus, and you were pushing really hard, and what can happen again is that uterus can kind of slip out. I think when that happens, it does not invert, because we talk about the pelvic floors kind of weakening and the uterus comes out. But again, uterine inversion, it's one of those kind of weird, untold story of the ER type things. We do not see that very often. So a woman with no risk factors may experience postpartum hemorrhage. So that's why we always check everybody, and we, again, do that through bundle check. Bundle check cues us about the uterus and uterine atony. A patient can still hemorrhage if the fundus is firm. The hemorrhage is from something else. fundus is firm, okay? She's still bleeding. Well, I'm not gonna keep massaging the fundus. Remember the joke in lab? Well, massage the fundus. I don't know what else to do. I'm gonna massage the fundus. Well, if the fundus is firm, that doesn't do anything. Is she bleeding from something else? Does she have a laceration? Does she have something else there? Now, with a boggy uterus, we see bright red bleeding, very large uterus. The height of the fundus is in the wrong place. So generally, we like it to be at the umbilicus or below. If you have a smaller baby, you're gonna start out lower. So let's say you have a preterm baby, your fundus may never be at the umbilicus. It might be 1 or 2 finger breadths below. So wherever your starting point is, it needs to decline. The other thing is, flip it around. Let's say you have a baby that's 12 pounds. 12 pounds? 12 pounds. If you have a 12-pound baby, you started out with the fundus 2 finger breadths above the umbilicus, but firm in midline, just because that uterus is really big. Okay? But for most of our patients, we tend to think umbilicus and below. And then each day, it will go down a finger breadth. And when you check the fundus, it's really important that you have the patient lie down. We don't want to do it in the patients in a semi-Fowler or high Fowler position. Head of the bed needs to go down. I see a lot of mother baby nurses, they never lower the head of the bed. They just come in, they kind of feel for the fundus, and they leave the patient sitting where they are. In terms of what would cue me into a laceration, the fundus is firm, but there continues to be bright red bleeding coming out of the vagina. And so typically, it's a vaginal wall laceration. The other thing is hematomas. So hematomas, sometimes they're visible. You might have a hematoma on the labia. It can be on the vaginal wall. Sometimes you can only see them with a speculum. What would cue me into a hematoma is that the patient's having significant pain that's not being alleviated with ice or any type of analgesic. The external ones you can see, the internal ones you can't. And actually what can happen is the patient's vital signs will start to change. So if you can't figure out what's going on, the doctor usually will come in and they'll do a speculum exam, and they actually might have to evacuate the hematoma. So they actually incise it, drain it, cauterize the bleeder, and sew it back up. So fundus is firm and changes in vital signs. And then subinvolution. Subinvolution is what you want. Involution is a good thing. Subinvolution is a bad thing. So with subinvolution, you have persistent lochia rubra. How long should you have lochia rubra?
3 days.
3 days, yeah. And I would say at the most, okay? Some people bleed longer than others. Some of it depends on, did you get a lot of that bleeding out of the way early, or, how's your bleeding been? But generally, when you're in the hospital, it's rubra. It's gonna then go to serosa. So how long do you have serosa? So a couple weeks, 10 to 14 days or so. And then you may have alba for about 3 weeks. That last little bit, it's kind of hard to tell. It's kind of tan or kind of a white. It's not necessarily drainage or discharge, but definitely you're not having to wear those big pads anymore. Okay. We don't want to see the drainage go backwards. So you don't want to go from rubra to serosa back to rubra. That's a sign something's not right. Okay. And then with these patients, sometimes their fundus kind of doesn't keep shrinking down. I've seen that, so you have a patient who will come in either through the ER or to the hospital,